All right, today we're going to break down one of the toughest injuries in all of orthopedics, the distal femur fracture. Now, this is not your average broken leg. Oh no, this is a really complex problem that requires a super precise strategic game plan from the surgeon. So, let's dive right in. So, let me ask you a question. What on earth could connect a crazy high-speed car crash with, a simple trip and fall? I mean, on one side, you've got this massive high-energy trauma, and on the other, an event that seems almost minor. Well, the thing that links them is the specific and pretty severe injury they can both cause.
And that injury is the distal femur fracture. We're talking about a break in the thigh bone, the femur, right there just above the knee joint. And what's really interesting about this fracture is that it has what we call a bimodal distribution. It basically means it has two peaks, and it affects two totally different groups of people.
Now, make no mistake, the stakes for this fracture are incredibly high. This is not a simple fix. For a young patient, it's all about getting them back to their active life. But for an elderly patient, it's often about just maintaining their independence. In both situations, the surgical outcome is absolutely critical.
So let's paint a picture of these two different patients. You have younger people, usually men, where it takes a huge amount of force. We're talking car accidents, major falls from a height, to cause this kind of break. But then you have older patients, typically women with weaker osteoporotic bone, where it can happen from just a simple fall at ground level.
And this number right here, well, it's a really sobering one. For geriatric patients, a distal femur fracture carries a 1-year mortality rate of 35%. I mean, just let that sink in. That is a staggering number, right on par with a hip fracture. It just goes to show how incredibly serious this injury is for the older population.
You see, to treat this fracture, a surgeon can't just go in and start fixing the bone. They need a detailed plan. And that plan, it all starts with a blueprint, a universal language that surgeons all over the world use to describe fractures. It's called the AO/OTA classification system. The best way to think about this is like the Dewey Decimal System, but for broken bones. The femur is bone number 3. The distal or lower part of that bone is segment 3. So every single distal femur fracture classification starts with the code 33. This simple code tells any surgeon anywhere exactly where the injury is.
Okay, so after that 33, you get a letter, A, B, or C. And this letter tells the surgeon the most important thing they need to know. Does the break actually go into the knee joint? A is extra-articular, so it's outside the joint. B is partial articular, so it just nicks part of the joint. And C, well, C is the most complex. That means the joint surface is completely broken off from the main bone.
So let's see what this looks like in the real world. Over on the left, you've got a simple type A fracture. See? A nice clean break above the joint. But on the right, that's also a type A, but it's multifragmentary. The bone is in a bunch of pieces. So while they're both technically outside the joint, you can see that the one on the right is a whole different level of surgical challenge.
Now we're moving into the joint with a type B or partial articular fracture. What this means is that a piece of that smooth joint surface, one of the condyles, has just snapped off, but the rest of it is still attached to the femur. The surgeon's #1 goal here is to restore that cartilage surface perfectly. If they don't, that knee is not going to function properly.
And here we have the most severe pattern of all, the type C, the complete articular fracture. Look at that. The entire joint surface is just shattered and totally separated from the shaft of the femur. This is a 3-dimensional jigsaw puzzle that the surgeon has to put back together piece by piece to have any hope of giving the patient a functional knee again.
Okay, so once the surgeon has that blueprint from the AO/OTA classification, they've got to pick the right tools for the job. So let's open up that toolbox and look at the main options for fixing this really complex injury.
At the end of the day, it usually comes down to a choice between two main pieces of hardware: an intramedullary nail, which goes inside the bone, or a locking plate, which gets fixed to the outside of the bone. And each one has a totally different philosophy and its own set of advantages.
First up is the retrograde intramedullary nail. The surgeon makes a small incision at the knee and slides this rod up the hollow center of the femur. It basically acts like an internal splint. Because it's a load-sharing device, it carries stress right alongside the bone, which can actually help it heal. Plus, this less invasive approach means less damage to the muscles and blood supply around the fracture.
The other option is the lateral locking plate.
This is a pre-shaped plate that gets secured to the outer surface of the femur with special locking screws. Now, its biggest advantage, and it's a huge one, is that it lets the surgeon see the joint surface directly so they can reassemble it perfectly. And that's why it's so often the go-to choice for those really complex type C fractures.
So when you actually compare these two, what does the data tell us? Well, this table from a study really lays out the trade-offs. The intramedullary nail, look at that, it's linked to way less blood loss and, on average, a slightly faster healing time. And those are really big factors that a surgeon has to weigh when they're making a decision.
All right, now we get to the really tough stuff, the special cases and the debates that are happening right now in orthopedic surgery. This is where the standard playbook, well, sometimes it just isn't enough.
One of the absolute biggest challenges is the periprosthetic fracture. This is when a patient who already has a total knee replacement breaks their femur right above it. Now the surgeon has to fix that new break without messing up the old implant. And if that old implant is loose, the entire game plan changes, sometimes needing a massive, massive revision surgery.
Now for what might be the single most important kind of exam pearl in modern fracture care. What do you think this number means? 21%. That is the percentage of orthopedic trauma surgeons who are comfortable letting their patients put their full weight on their leg right after surgery when they've used the most common implant, that lateral locked plate. Just 21%. That's it.
In this chart, wow, it is so revealing. I mean, look at the huge gap in confidence. Only 21% of surgeons say, go ahead and walk on a locked plate, but that number jumps to 64% for a nail and all the way up to 80% if they use a dual implant. So why the massive difference? It's because the nail is just a better load-sharing device. And this hesitation to let patients walk has huge implications for the recovery of geriatric patients.
So how do we get these fragile patients up and moving sooner? For a lot of surgeons, the answer is just to build a stronger structure. This has led to the rise of dual implants. Think of it as a belt and suspenders approach. By using both a nail and a plate, or sometimes two plates, surgeons can create a much more rigid fixation. This gives them the confidence to let patients get on their feet earlier.
And this quote from the medical literature just perfectly captures the central conflict here. We have all these amazing, advanced implants, but we're still fighting against the reality that frail patients cannot stay off their feet for long. Not being able to bear weight leads to this cascade of awful complications, pneumonia, blood clots, which is exactly why that 35% mortality rate is so tragically high.
And that really brings us to our final thought. The engineering behind these nails and plates is just incredible, but even the strongest implant can fail in weak bone or in a patient who just can't participate in rehab. So as we face this aging population, maybe the ultimate question isn't about inventing a better piece of metal, but about how we can better manage the vulnerable human being who is attached to the fracture.